The floor is open for questions. If I may I take the first question? You presented very nicely the DNA fragmentation, especially the double-stranded option. The thing is that something that is tormenting us is what we do. How can we improve that? And in our arsenal, basically, apart from supplements, diet supplements, we don't have much really. And from what I gained from your speech is that do you suggest any of those treatments that are controversial, obviously, well, there is no trials, RCTs to confirm that. Apart from the zymote options, the macrofluidics to help us to choose the right spermatozoa for the ICSI procedure, do you suggest anything else?
So, of course, that is the question, because we all ask the question, what can we do to make this better? And when we've asked another question, which is, why did it all go wrong? And we've got an answer, but we can't fix it. It's all rather unsatisfactory, except for the patients, because they do want to know. It's bad news in my practice. Let's put this in context. The lab that does this test have run about 320 tests since this test became commercially available. And of those requests for tests, 250 came from my practice. So that is my experience that I'm sharing with you in this conversation. There's a bit more data that comes from Barcelona, from Jordi's case, but he and I talk a lot. And so far, there isn't, it seems, any solution to this, any therapeutic solution, other than better sperm selection. We're going to try and take the diagnosis further because we've frozen all the specimens with consent from the men with high double-strand breakage, and we will be able to do whole genome sequencing or whole exome sequencing on their DNA. And I suspect for the first time, we will see point mutations. So we're going to get closer to the diagnosis. Now, we're an awful long way from engineering those mutations, but if we're looking for a therapy, if we're looking to look after the next generation, then that's where we may get to. But a few fewer cups of coffee a day and eating broccoli and nuts, I don't think that's going to make any difference to your double-strand breakage.
Thank you. Guys, anybody?
Professor Ramsey, congratulations for your speech. I always felt personally that DNA fragmentation is significant, and I do test it routinely. My question is, because it's designed as the percentage reported for the DNA fragmentation as a range from 0, 1 to 31%. Quite often I see people say, well, it's normal, but it's 31 or 30. Wouldn't 3% be much better? And could this be the reason why 31 is actually masking something that we are reporting as normal, when we should be digging further? That's how I look into it.
Straight answer, yes.
And one follow-up very quickly is looking into the reason why the fragmentation is high, apart from rare conditions. Do you think chronic infections or subclinical infection for men could be masking this, could be the reason?
So I think when you're looking at high fragmentation, single-strand breakage, then chronic infection is pretty high on the list. And those elements of prostatitis, in inverted commas, that may be related to an abnormal microbiome, an imbalance of organisms, urea plasma plus anaerobes is bad for your prostate and bad for your sperm. But I don't think that situation has any effect on the double-strand breakage. So you may improve the single-strand breakage by treating the man, and it may be then that there are natural pregnancies. But if there's a high underlying double-strand breakage, you may well be looking, firstly, at a higher, this is just my view, at a higher early miscarriage natural conception rate, and it just might be the case, here's the big conversation, that this is contributing to the failure of euploid embryos.
Thank you very much. You have this.
Yes, that's good, yes. Jonathan, thank you for the narrative. I really appreciate your focus on the double-strand break. It was time. I have a little comment and a short question. The little comment is that this narrative is still suffering an issue from the basic science, metabolism. Double-strand breaks do not depend on oxidative aggression. We don't have any mechanism for that. It is when you have a sperm with the DNA extensive fragmented, it is the schistors, proteases. As nothing, the oxidative aggression can oxidize guanosine. You can have in a basic site. Eventually, this turns into a single-strand break. But the double-strand break is a question mostly of the protemination phase. And this is what we have to investigate. It has nothing to do directly with oxidative aggression. And this is the main point, because as long as the clinicians look at the other side, we do not progress. We have to change our mindset on this story. Then the question, and that is the sperm selection. We very well know that an extensively fragmented sperm has very little, no chances to be selected for ICSI, has no chances to fertilize in IVF, even less into a natural fertilization. The problem is that we know that once a large rate of the sperms into an ejaculate are fragmented, something went very wrong in the maturation of those sperms. This is likely affecting also the non-fragmented one. Do you really think we can improve, put a remedy to this with sperm selection? This is the real point. And this is the question. Do you believe we can do that? Because this is the problem.
So I absolutely don't know, but what I believe we can do is to try to understand why, for example, measurably, in about 90% of the men who have double-strand breakage, that double-strand breakage percent falls to the normal range with usually the 850 microliter Zymod, usually. In 2 or 3 cases, it didn't respond to the 850, but it did to the old-fashioned 3 milliliter. Now, which of course, for people of our age, that's what it was designed for, IUI. And it may well have been working in IUI and would have gone on working had not ICSI come in and swept the board. But what we're going to try and do from January is to image analyze in 3D the tail movement of these damaged sperm, so that we might be able to predict which ones may and may not go through what we currently have, which is called a microfluidic separator, but it isn't really. And we might be able to design a better one. But I think the key is going to come, the real answer to that important question, is when we do the whole exome sequencing of the sperm with an apparently lower double-strand rate, to see whether those genetics are also being selected out.
It's an excess of mutations because of the genetic instability from contamination. I do that.
Thank you very much. Dr. Christopoulos now with a question.
Welcome, Professor Ramsey. Thank you very much for being here. And please allow me to express all the RCOG subspectrini's gratitude for your pivotal role as a clinical trainer and mentor. The question I have, however, today is a bit more pragmatic. So Zymot is a simple plug. So if Zymot has so much better results, wouldn't it be more practical to unplug the centrifugator in a sperm lab and offer Zymot to all our patients as a blanket policy?
Sure.
Have you seen any cases where Zymot might actually do more harm than good?
Yes, George. And so in my practice, I never recommend the Zymot, firstly, until I know that it's double-strand breakage, because that's what it's working for. And secondly, do a test run, because somewhere between 5 and 10% of patients are no better, and I've seen now 3 were actually worse. So, and again, the question is not so much how to make them better. The real question is why. What is it that we're missing that we can't predict this accurately enough to say, let's just do Zymot in everybody? The company that does the double-strand breakage is, and I'm not in any way financially or conflicted with them, but they are always really reticent when I come to a meeting like this and put double-strand breakage in the same sentence as the word Zymot, because they say all the doctors will stop measuring the double-strand breakage, they'll just use the Zymot. Yeah. And of course there's a risk of that, but I would implore you not to, because I think what we haven't done in our field, really over the last 30 years, is to do what we do in every other branch of medicine, which is to make a diagnosis.
Thank you.
Μπορώ να το κρατήσουμε στα αγγλικά για να μπορεί να παρακολουθήσει και ο συνομιλητής μας. Can I put forward a question to Donis Makrigiannakis? I think that it was it's like a race. You mentioned in many of your talks the 3 checkpoints. Measure that as like a Formula One, and today's speech is top model is the microbiome. Do you believe that the microbiome of the sperm is something that we missed all that time and probably plays a crucial role to the outcome or to putting down our management to the infertile couple, especially with recurrent implantation failures?
Okay, thank you. First of all, as I mentioned in my talk, that microbiome of the sperm is really important and is affecting the microbiome of endometrium. This is clear, it is proven, and there are some studies showing that. Now, from the point that if we need to put in the routine practice the microbiome of the sperm, since we cannot propose this from the endometrium, I cannot recommend it from the sperm. We still need some more, in putting in routine practice. Definitely, according what we have to see, if the microbiome, if it is affected, if it is having an effect in this double strand effect in the sperm, and in that case, I would recommend yes. But we don't have this proof yet.
Thank you. Thank you. Is anybody else? Okay. Thank you very much, everybody. Thank you.